CE presentation on our resident research projects. So if you are not familiar with what these research projects are for or what they entail, our PGY1 and PGY2 pharmacy residents spend a year conducting a longitudinal research project. That's a requirement as part of their ASHP residency graduation requirements, but also is something that they and their co-investigators are really proud of. They're really meaningful and impactful projects. And they will be traveling to the Southeastern Residency Conference later this week to present these alongside other residents from many, many different residency programs to share some of the things that we're doing here at Erlanger in terms of pharmacy research. So we will move through the first presentation, which is going to be Abby Mason. And she'll introduce herself, and then we'll kind of follow in alphabetical order by first name with the rest of the residents after Abby. And if you are a audience member who is filling out a evaluation form, if you'll please bring those to me when you're done, or if you're watching via Zoom or Teams, if you don't mind to either drop those by my office or you can scan them into my email. Thanks.
Good afternoon, everyone. Thank you for joining. I'm Abby Mason. My project today that I'll be discussing is the implementation and analysis of a pharmacist-managed heparin infusion service at an academic medical center. Before we begin, I have no disclosures to make about this project, and here are some abbreviations that will be used throughout this presentation for reference. Our objective is to evaluate the difference in time to therapeutic anticoagulation between a nurse-managed and a pharmacist-managed heparin service. For some background, heparin is commonly used for hospitalized patients requiring therapeutic anticoagulation, particularly when oral anticoagulation is not an option. However, heparin therapy it can be challenging due to its variable pharmacokinetics, which can differ from patient to patient. In 2022, an internal medication use evaluation at Erlanger looked at our current heparin infusion service and identified suboptimal time to first therapeutic APTT and poor time in therapeutic range. In response, the pharmacist-managed heparin service was implemented in 2023 to address these gaps. To give some context, Erlanger is a large academic medical center with 546 adult beds. Our pharmacy heparin services manages about 15 patients daily. And then our pharmacy staffing model is a hybrid of central staff pharmacists and decentralized clinical pharmacists. Our primary outcome was the time to first therapeutic APTT after initiating a heparin infusion, comparing the new pharmacist-managed service to the historical nurse-managed protocol. Our secondary outcome was evaluating the time to first therapeutic, to give some context, evaluating time to first therapeutic APTT is a value historically evaluated in the literature and is valuable because delayed anticoagulation increases the risk of thrombosis. Faster time to therapeutic APTT can lead to fewer lab results required throughout treatment and is a more simplified way to quantify success of a heparin protocol service, since time at therapeutic range can be affected by many different variables, such as variable pharmacokinetics and heparin being paused for procedures. Our secondary outcomes included adherence to the protocol and percent of APTTs that are in therapeutic range and percent of APTTs that are outside of therapeutic range. Many hospitals have implemented pharmacist-managed heparin services, but these services vary significantly across institutions. For context, I'll walk us through what our specific heparin service looks like at Erlanger. The process begins when a provider places a heparin order. This order alerts the staff pharmacist, who then ensures the initial heparin infusion rate is correct and orders subsequent APTTs. The pharmacist then reviews the APTT results, adjusts the heparin rate and bolus doses as needed, and places orders if the APTT is supertherapeutic. They also order the next timed APTTs based on the protocol. The nurse then programs the new pharmacist ordered rate into the IV pump and draws follow-up labs as ordered. At Erlanger, we use three different heparin protocols: standard dose, reduced dose, and low dose. Standard dose protocols are usually used for conditions such as acute DVT, PE, intracardiac thrombus, atrial fibrillations, and other scenarios requiring therapeutic anticoagulation where oral agents are not appropriate. Reduced dose protocols are used for patients with acute coronary syndrome and other patients requiring anticoagulation with an increased risk for bleeding. And finally, the low dose protocol is reserved for cardiothoracic surgery patients, patients with trauma-related blunt cerebrovascular injury, and others at a high risk for bleeding who still require anticoagulation. For this project, we compared two groups, a nurse-managed group and a pharmacist-managed group. Nurse-managed group data was collected during an internal medication use evaluation conducted from December 2021 to February 2022. At that time, heparin was dosed by nurses using a heparin calculator that was used to guide rate adjustments. Pharmacist-managed group data was collected specifically for this study from March to June 2024. Pharmacists in this group dosed heparin according to updated institutional protocols. The study design was a retrospective observational analysis. Our inclusion criteria were patients that were 18 years or older and that received more than 24 hours of either the standard, reduced, or low dose protocols. Our exclusion criteria was patients with a baseline APTT that was greater than 40 seconds or received heparin through a non-protocol infusion. Comparing their demographics between groups, the number of APTTs per patient was statistically significant, with patients in the nurse-managed group averaging 9 PTTs per patient compared to 8 APTTs in the pharmacist-managed group. Heparin duration was also statistically significant, with a median of 3.6 days in the nurse-managed group and 2.6 days in the pharmacist-managed group. For indication and location, there were variations between the groups, except for indications of DVT and PE. Regarding dosing protocols, there is no statistically significant difference between groups in the use of standard and reduced dose protocols. However, significantly more patients were treated on the low dose protocol in the pharmacist managed group. Finally, more patients underwent procedures while on the nurse managed group than on the pharmacist managed group. Our primary outcome was the time to the first therapeutic APTT or higher. In the nurse managed group, the median time to reach therapeutic APTT was 10.1 hours. In the pharmacist managed group, the median time decreased to 6.3 hours, which was statistically significant. When broken down by protocol type, for the standard dose protocol, time decreased from 10.4 hours to 6.3 hours. For the reduced dose protocol, time decreased from 10 hours to 6.4 hours. And for the low dose protocol, time decreased from 9 hours to 6.2 hours. All protocol groups showed a statistically significant improvement. In secondary outcomes, in the nurse managed group, about 40% of APTT checks were subtherapeutic. In the post-protocol group, this decreased to 31% subtherapeutic checks, which was statistically significant. There's also a statistically significant increase in percentage of therapeutic APTT checks in the pharmacist managed group compared to the nurse managed group. There is no statistically significant difference between the groups in the percentage of supertheric APTT checks or APTTs above 150. Another secondary outcome we assessed was protocol adherence. We evaluated whether the pharmacist ordered the heparin bolus correctly if indicated, ordered the correct infusion rates, and adjusted the infusion rates appropriately based off of the results. We analyzed 50 patients during the first 48 hours of therapy, reviewing 130 unique pharmacist orders. Only 6 orders deviated from protocol, giving a protocol adherence of about 95%. The median time from lab result to pharmacist order entry was 4.5 minutes, and the median total time from lab result to the nursing rate change in the MAR was 18 minutes. In conclusion, a pharmacist-managed heparin service was associated with a faster time to achieving first therapeutic APTT or higher across all protocols. It also showed a statistically significant reduction in subtherapeutic APTTs and a statistically significant increase in therapeutic APTTs. Importantly, there is no increase in supertherapeutic APTTs. There are several limitations to consider. Our nursing still has to manually program the IV pumps, so any mistakes or delays in that step could affect outcomes. During the study period, the starting heparin rate in the standard dose protocol was changed from 16 units per kg per hour to 18 units per kg per hour, which may have contributed to improved therapeutic rates in the pharmacist managed group. Patients frequently move between hospital units, which can impact nursing ratios and timeliness of lab draws. When looking at protocol adherence, some deviations from protocol during adherence review may have been reflected appropriately by clinical judgment by pharmacists, not necessarily protocol errors. And as a next step that could be considered would be to implement bidirectional pumps, which would allow pharmacists to control more closely the rate change on the pump. For our self-assessment question, Erlanger's pharmacists manage heparin services causes significant delay in care and increased time to therapeutic anticoagulation. True or false? False. Erlanger's pharmacists manage heparin service is associated with a decreased time to therapeutic anticoagulation and has a median turnaround time of only 4.5 minutes from lab result to pharmacist order. Thank you to my team, and I'm open to any questions. We're gonna move to the next.
All right, so I'm going to be talking about the utility of clonidine conversion to prevent withdrawal from dexmedetomidine in pediatric patients. My team and I have nothing to disclose. And these are some of the abbreviations that will be mentioned in this presentation. So the study site is a level 1 trauma and academic medical center that houses the only children's hospital in the region, and it is licensed for 133 pediatric beds, including a PICU and a level 4 NICU. So a little bit of background, in 2022, SCCM released a guideline update that recommended alpha-2 agonists as the preferred class for sedation in critically ill pediatric patients. But since this increase in alpha-2 agonist use, there has been concern about potential dexmedetomidine withdrawal, but recent evidence has supported the use of clonidine as a bridging agent. However, there is no consensus or validated protocol that exists. So the purpose of this study was to look at the relationship between cumulative dexmedetomidine exposure and enteral clonidine requirements. This was a retrospective observational study that identified patients admitted to the PICU with continuous dexmedetomidine and enteral clonidine from January 2018 to May 2024. Data was collected via retrospective chart review, and then for statistical data comparisons, a t-test was performed for numerical data, and a Wilcoxon test was used for all non-parametric data. So when we're looking at the study protocol, our inclusion criteria was patients who were admitted to the PICU with continuous dexmedetomidine infusion for at least 24 hours, as well as enteral clonidine for the treatment or prevention of dexmedetomidine withdrawal. Our exclusion criteria included use of clonidine prior to admission, initiation of clonidine for an alternate indication, or transfer to another institution or death. So we screened 179 patients, with 100 of them being excluded. The majority of patients were excluded due to either clonidine use prior to admission or clonidine initiation for an alternate indication. Notably, we did divide the included patients into two groups, a non-escalation and an escalation group, with the escalation group being comprised of patients who required an increase in their clonidine dose after initiation, but this increase was at the discretion of the provider. So when we're talking about the primary outcome examined the relationship between cumulative dexmedetomidine exposure and the maximum required clonidine dose, whereas secondary outcomes included hospital and ICU length of stay, ventilator days, central line days, incidence of tracheostomy, and then dexmedetomidine withdrawal assessment. So this is how we define the dexmedetomidine withdrawal assessment. This was in the escalation group only and was based on the 2 readings immediately prior to the clonidine dose increase. So we looked at values in the 90th percentile or higher based on age and sex for systolic blood pressure and heart rate. And then we defined an elevated withdrawal assessment tool as greater than 5 and an elevated RAS score as greater than +1. All right, so when we're looking at our demographics, notably the escalation group did have a statistically significant younger age than the non-escalation group. This could potentially be due to an increased requirement of sedation in these patients or a higher proportion in this group that were admitted to the PICU from the NICU. Otherwise, the baseline characteristics were fairly similar across the 2 groups. All right, so when we're talking about the results of the primary outcome, this is a visual representation of the primary outcome, which, as a reminder, looked at the relationship between cumulative dexmedetomidine and maximum required clonidine dose. So just to orient you, this is a scatter plot that shows the cumulative dexmedetomidine dose in mics per kg on the x-axis and the maximum clonidine dose received in mics per kg per day on the y-axis. Notably, this chart does include patients from both the escalation and non-escalation groups, with the escalation group being blue and the non-escalation group being orange. As you can see, with increasing cumulative dexmedetomidine dose, there is also an associated increase in maximum required clonidine dose per day. So this equation here represents the relationship between the 2, and the hope is to be able to eventually look at using this equation to standardize conversion from dexmedetomidine to clonidine in these patients. So this is more of a numerical representation of the primary outcomes. So as we can see, patients in the escalation group had a statistically significant increased duration of dexmedetomidine, as well as increased cumulative dose of dexmedetomidine, and an increased duration of overlap between the 2 agents. Notably, the initial clonidine dose was similar between groups, which is important because it indicates that the clonidine increases were not due to lower starting doses in the escalation group. So moving on to secondary outcomes. So this is our dexmedetomidine withdrawal assessment. So we had 49 patients in our escalation group, but unfortunately, as this was a retrospective study, all of the components of the withdrawal assessment were not available for all patients. So in each bubble, the number is the amount of patients that had the measurement available. So as you can see, 57% had an elevated systolic, whereas 51% had tachycardia, 20% had an elevated WAT1, and 15.4% had an elevated RAS of the ones that had it available. When we're looking at the rest of our secondary outcomes, we can see that both hospital and ICU length of stay were significantly increased in the escalation group. And additionally, while they weren't statistically significant, ventilator days, central line days, and incidence of tracheostomy were all increased in the escalation group. And given the small sample size, it is possible that with an increased sample size, we would have seen more significance. So in conclusion, increased cumulative dexmedetomidine exposure was associated with higher clonidine dose requirements. Both hospital and ICU length of stay were significantly decreased in patients who did not require an increase in clonidine. And then utilizing cumulative dexmedetomidine exposure to determine initial clonidine dose may be beneficial in bridging these patients. As far as future steps, implementing a protocol that allows for more standardized conversion of dexmedetomidine to clonidine bridge, as discussed with the primary outcome graph and utilizing that equation. Evaluating whether the use of clonidine dosage based on cumulative dexmedetomidine exposure prevents the need for a clonidine dose increase, and then implementing more specific alpha agonist scoring, such as the newly developed WAT A2A scoring consistently. So for our self-assessment question, true or false, increased cumulative dexmedetomidine exposure was associated with higher required maximum clonidine doses during hospital stay. True. And I'd like to thank my team. And with that, I'll take any questions.
All right, good afternoon, everyone. My name is Fatima Kulani, and today I'll be presenting my research over assessment of phenobarbital utilization for alcohol withdrawal. I'd like to briefly mention that I have no disclosure to report. Oh, actually. Sorry. Is that yours? Sorry. This is a list of abbreviations that will come up throughout this presentation. I included them here for your reference. And the objectives of this study is to compare the effectiveness of 3 different strategies for managing alcohol withdrawal syndrome. These include a scheduled phenobarbital regimen with additional PRN doses, phenobarbital combined with as-needed benzodiazepine, and benzodiazepine monotherapy, including scheduled and PRN doses. To understand how these agents work, it's important to understand how alcohol affects the brain. So in a normal state, when a person does not have alcohol in the system, we have a balance between GABA, which is our inhibitory neurotransmitter, and glutamate, which is an excitatory neurotransmitter. When someone drinks occasionally, alcohol enhances GABA activity, tipping this balance temporarily toward inhibition. With chronic alcohol use, the brain adapts by upregulating glutamate to maintain balance and mimic normal homeostasis. So even though alcohol is still increasing GABA, the brain compensates by making more excitatory neurotransmitters. And in withdrawal state, alcohol is suddenly stopped, leaving glutamate unopposed, which causes CNS hyperactivity, and that's what leads to withdrawal symptoms like tremor, seizures, and DTs. So the main 2 agents that are used for alcohol withdrawal syndromes are benzodiazepines and phenobarbital. Benzodiazepines help by enhancing GABA activity in the central nervous system. They have rapid onset of action, and they're recommended as first-line treatment for alcohol withdrawal by the American Society of Addiction Medicine. Phenobarbital, on the other hand, works through a dual mechanism of action. It enhances GABA activity and inhibits glutamate receptors. That broader mechanism of action may offer a more comprehensive approach, but it's currently recommended only as an adjunct for patients who are benzodiazepine resistant or have contraindications. So there is a growing body of recent retrospective studies supporting phenobarbital use in alcohol withdrawal syndrome. These studies shown that patients treated with phenobarbital tend to have shorter hospital and ICU stays, lower 30 days readmission rates, and overall favorable safety profile compared to benzodiazepines. This study was conducted at Erlanger Hospital, which is a level 1 trauma and academic medical center with 546 adult beds. For our methods, it's a single center retrospective observational review, and data were collected from October 2017 till October 2024. For our inclusion and exclusions, we included adults treated for alcohol withdrawal syndrome at Erlanger, and we excluded cases with co-founders like chronic benzodiazepine use or barbiturate use, receipts of both scheduled benzodiazepines and phenobarbital at the same time, and incomplete CEWA documentation. This slide shows our institution's phenobarbital protocol, which includes both IV and oral tapers. Dosing is adjusted based on whether the patient has history of DTs, active DTs, or neither. We use this protocol consistently for patients in both floor and ICU setting. This slide shows our institution's benzodiazepine protocol with different agents. The choice of treatment and tapering strategies was left to provider discretion with no restriction on dosing or taper duration. So for the primary outcome, we defined it as time to clinical stability, which was defined as resolution of withdrawal symptoms or hospital discharge, whichever occurs first. Resolution of withdrawal symptom was defined as CEWA score of less than 8, or no PRN doses administered for 48 consecutive hours. Secondary outcomes were the use of adjunctive treatments and incidence of withdrawal seizures, and safety outcomes were the need for mechanical ventilation secondary to treatment, incidence of sedation, and hypotension, which was defined as held scheduled doses due to sedation or hypotension. The baseline characteristics were generally comparable across groups, but a few differences are worth highlighting. The phenobarbital monotherapy group had notably higher proportions of males at 87% compared to 59% and 72% in the other two groups. The phenobarbital monotherapy group had a higher baseline CEWA score of about 21 compared to 13.6 and 19.2 in the other two groups. And ICU admission rates were significantly higher in the phenobarbital monotherapy group at 47%, around 47%. For the results, looking at time to clinical stability, which was our primary outcome, the phenobarbital monotherapy group achieved this outcome by about 1 full day faster than the benzo monotherapy group and about a day and a half faster than the phenobarbital with the PRN benzodiazepine group. For our secondary outcomes, adjunctive medications were required in 31.7% of the phenobarbital-only patients compared to 36% in the phenobarbital with the PRN benzos and 43% in the benzo monotherapy group. So there's a trend toward a lower adjunctive medication use in the phenobarbital monotherapy group. Withdrawal seizures occurred in a total of 6 patients, 3 in the phenobarbital with the PRN benzodiazepines and 3 in the benzodiazepine monotherapy group, and no seizure events were reported in the phenobarbital monotherapy group. For our safety outcomes, incidence of sedation was higher in the phenobarbital with the PRN benzodiazepine group and benzodiazepine monotherapy group at about 15% compared to 6.6% in the phenobarbital monotherapy group. Notably, no patients in any group required mechanical ventilation, and only 1 patient had a hypotension incidence in the phenobarbital with the PRN benzodiazepine group. This slide compares CEWA scores at different time points across treatment groups. It shows CEWA score prior to treatment initiation and highest and lowest CEWA score 48 hours after treatment initiation. As you can see, the phenobarbital monotherapy group started with higher CEWA score at time of treatment initiation, but showed the greatest reduction by 48 hours. For conclusion, phenobarbital monotherapy group was associated with faster clinical stabilization, fewer adjunctive medications and seizure events, lower rates of hypotension and sedation, and greater reduction in CEWA score within 48 hours despite higher baseline severity. For some of the limitations of this study include the non-standardized dosing due to provider preference, variability in CUS scoring and clinical judgment, potentially leading to variation, and having small sample size, which limits our ability to conduct additional subgroup analyses. And lastly, post-discharge follow-up was not assessed in this study. And this is my self-assessment question. Based on the findings of this study, which of the following was observed in patients who received phenobarbital monotherapy? A, increased sedation-related adverse events. B, faster time to clinical stabilization. C, greater use of adjunctive benzodiazepines. And D, higher CUS score at 48 hours. It's B, faster time to clinical stabilization was associated with phenobarbital monotherapy. I'd like to thank my co-investigators for their support and guidance throughout this project. Now I'll open it for questions, if any.
Sorry if you said this, but how did you define covert sedation?
It was defined as held doses secondary to sedation. So if they have a scheduled dose and the nurse was not able to administer it, that will be considered as an incidence.
Okay, my name is Lauren, and I will be discussing my research project on the impact of required stop times on continuous IV fluids on duration of fluid therapy. None of the investigators nor myself have any disclosures. And here are the featured abbreviations that will be utilized throughout this presentation. As a little bit of background, continuous IV fluids are widely administered in hospitalized patients for indications such as sepsis, pancreatitis, or volume depletion. However, inappropriate or excessive use is associated with adverse effects such as AKI, volume overload, respiratory complications, as well as electrolyte disturbances. Despite this evidence, recommendations for fluid management are lacking. The British Consensus Guidelines on IV fluid therapy in adult surgical patients recommend utilizing electrolyte and fluid balance with careful monitoring via weights as well as physical exams as guiding principles. It's also important to note that they state that IV fluids should not be continued as routine components of care. Our solution was the implementation of a pharmacist-led initiative which required stop times to be placed on all continuous IV fluid orders. The purpose of our study was to compare the duration of continuous IV fluids administered before and after the implementation of the required IV fluid stop times. Specifically in our patient population admitted to our hospitalist services comprising of non-ICU beds. This study was conducted at Erlanger Baroness Hospital, which is an academic medical center. Each day, there are an average of 7 hospitalists rounding on 20 to 25 patients, and we chose to look at the hospitalist service line to assess the impact of a pharmacist-led initiative in a service area without clinical pharmacists that are currently rounding. For our methods, this was a single-center retrospective study in which a total of 609 patients were screened for inclusion, ultimately including 350. In July of 2023, hard stop times were built into the electronic medical record when orders were placed for continuous IV fluids, requiring stop times to be placed. Here I've included an example of what providers would see when they enter an order for a continuous IV fluid. As you can see, a stop time with either hours or days are required in order to actually place the order for pharmacists to verify. We included adults that were admitted to the hospitalist service for at least 24 hours and also had continuous IV fluid orders for at least 12 hours. Important exclusion criteria include transfer from outside hospital, as we could not quantify the volume of any fluids that might have been administered prior to arrival at our facility. We also excluded patients who received continuous IV fluids for indications that might require specific rates or volumes of IV fluids, such as DKA or pancreatitis. Our primary outcome was the duration of fluid therapy until hospital discharge or 30 days after fluid initiation. For secondary outcomes, we looked at maintenance fluid volume at day 5, with day 5 being our time frame because this was our institution's average length of stay. We also looked at our hospital length of stay as an important secondary outcome, with our safety outcomes including electrolyte disturbances, incidence of fluid overload, as well as looking at renal replacement therapy requirements, diuresis, ICU admission, or increased oxygen requirements secondary to volume overload within 3 days of fluid therapy. We defined fluid overload as BNP greater than 400, or as the documentation of surrogate search terms, heart failure exacerbation, edema, or volume overload in the electronic medical record. We also defined increased oxygen requirement as documentation of acute respiratory failure within the EMR, or if the FiO2 requirement had increased over 6% from baseline. We defined electrolyte disturbances as previously done in both the SPLIT and SMART trials. For our baseline demographics, groups were well matched at baseline. We also assessed for comorbidities that may impact a patient's ability to become fluid overloaded, with a higher incidence of these in our post-protocol group as compared to our pre-protocol group. Now we can discuss our results. With our primary outcome of duration of fluid therapy at 30 days, we found that our protocol implementation decreased fluid administration by an entire day. And here we have our secondary outcomes. We found that there was greater than 1 liter reduction in our median maintenance fluid volume in the post-protocol group as compared to the pre-protocol group, with a 24% lower incidence of fluid overload and 18% for our electrolyte disturbances. To control for length of stay, to ensure that patients did not have less volume administered due to being in the hospital for less days, we completed a linear regression analysis. And in doing so and controlling for hospital length of stay, the maintenance fluid volume was still statistically significant. For our safety outcomes related to fluid overload, we found a significant differences in the post-protocol groups with regard to both diuretic requirements as well as oxygen requirements. In conclusion, the implementation of the required stop times on continuous IV fluid orders led to reductions in administration duration as well as maintenance fluid volume. Further evaluation should be performed to assess the role that these stop times play in reducing hospital costs as well as in improving patient outcomes. Ultimately, we found that benefits were seen from a pharmacist-led initiative and a service line without routine clinical pharmacy rounding. I would like to give a special thanks to all the members of the research team. And finally, I have my assessment question. True or false? Implementation of required stop times on continuous IV fluid orders was associated with shorter duration of fluid therapy and less volume. True. We found that the implementation of our required stop times was associated with shorter duration as well as less volume. And now, in the conclusion of my presentation, I will open up the floor to any questions. Oh, yes.
Great presentation, great job. There are a couple slides where the boxes.
I noticed it did not look like that in any of the other ones that we did last week.
I was gonna say, is this screen resolution different from all other screens, or this is like smaller?
I don't know because we didn't encounter this last week when I was giving.
I got that.
No. No, because I just used the same laptop last week as I did like editing it throughout all last week and the week before. And it looked fine last week. I noticed it and I was just like trying to be unbothered, but I was like, this has not looked like this the entire time. Oh, yeah.
Okay. My name is Tylen DiGiacomo. I am the current PGY2 critical care pharmacy resident, and I'm excited to present my research comparing clinical outcomes in hospitalized patients that are receiving either olive oil-based versus soybean oil-based lipid emulsions as a component of parenteral nutrition. With that, my co-investigators and I have nothing to disclose, and I have included an abbreviation slide here for your review. Our study was conducted at Erlanger Baroness Hospital. We are an academic medical center and a tertiary referral hospital. Notably, we do have 7 adult ICUs, and we do have a pharmacy-led nutrition support service that is primarily run by our pharmacy residents. The purpose of our study was to compare the difference in clinical outcomes among our hospitalized patients receiving olive oil-based versus soybean oil-based lipid emulsions as a component of parenteral nutrition. What we do know is that parenteral nutrition has been shown to mitigate catabolic states derived from critical illness and malnutrition in patients that have contraindications that prevent enteral feeding. With that, intravenous lipid emulsions are an integral component of PN as they provide our essential fatty acids, linoleic acid and alpha-linolenic acid. However, that does not come without risk, as we know that the inflammatory properties of linolenic acid are implicated in the exacerbation of critical illness, infection, and liver injury. Therefore, we typically see some sequelae from this, including a PNAD, ALD, or peripheral nutrition-associated liver disease that typically occurs around the 14-day mark. Therefore, we have studied linoleic acid sparing strategies as a way to mitigate some of these adverse effects. Therefore, olive oil-based lipid emulsions have been proposed as they have about 1/3 the amount of linoleic acid compared to its traditional soybean oil-based counterpart. However, beyond theoretical implications, limited data exists related to the selection of lipid emulsion on clinical outcomes. This was an IRB-approved retrospective single-center observational study that included adult patients that had a confirmed receipt of either olive oil-based lipid emulsions or soybean oil-based as a component of PN. We excluded patients that arrived previously receiving parenteral nutrition, if their duration of PN was less than 3 days, or if they received both the olive oil and soybean oil lipid emulsions during the same hospitalization. Additionally, we did exclude patients that had a history of cirrhosis or noted on imaging, or if patients had a baseline bilirubin greater than 2 mg per deciliter or a serum triglyceride greater than 400 mg per deciliter. We recorded but did not exclude key medication and non-medication confounders, which I have listed for you here. Key medications that we wanted to screen for were those that are typically implicated in the inflammation of liver disease, such as our azole antifungals. We'll also see here amiodarone and some antibiotics, such as our macrolides. And we also included key non-medication confounders, including massive transfusion protocol. For statistical analysis, for all nominal data, we conducted a chi-square test, and then for continuous data, we conducted student t-test or Wilcoxon rank sum based on the distribution of data. Our primary endpoint was PN-ALD, which we defined as a total bilirubin greater than 2 mg per deciliter, or an elevation greater than 1.5 times the upper limit of normal, which was in accordance with our institution-specific protocols of at least one of the following, including AST, ALT, and ALPHOS. For key secondary endpoints, we wanted to see if there was any difference in the rate of hospital-acquired bloodstream infections, which we defined as greater than 48 hours from central line placement. Other key secondary endpoints were both hospital and ICU length of stay, in addition to the rate of hypertriglyceridemia. We'll see our baseline characteristics here. We can see that overall they're pretty evenly matched between groups. A couple of things that I wanted to point out was the receipt of SMOF. So SMOF is also considered a linoleic acid sparing strategy. We can see that 2 patients in the soybean oil-based group did receive this. It includes soybean oil, olive oil, and fish oil. However, the patients that did receive this, their duration of SMOF was shorter than that of the soybean oil-based lipid emulsion. Other things to point out for you guys is the duration of parental nutrition. The duration was 8 to 9 days respectively in our study, and then most patients were receiving parental nutrition for the indication of either ileus or a small bowel obstruction. Continuing with our baseline characteristics, a couple of things that I wanted to point out for you here is that some patients, more so in the olive oil-based group, were receiving amiodarone, which was statistically significant at baseline. In addition to antibiotics and NSAIDs were more common in our soybean oil-based group. But overall, we can see that rates of ICU admission and mortality were similar between both groups. With our primary endpoint, which again is parental nutrition-associated liver disease, on our y-axis here, we'll see the number of patients, and then on our x-axis, those that achieved the primary endpoint. In our olive oil-based group, we did see 35 patients achieve this endpoint compared to 28 in the soybean oil-based group, which was not statistically significant. Moreover, with our secondary endpoints, we didn't see any statistical difference in any of our key secondary endpoints. With hypertriglyceridemia, we can see that they're pretty comparable between groups, even when separated out to moderate and severe. With nosocomial bloodstream infections, the most common bloodstream infection that we saw was E. coli, and then 1 patient in the olive oil-based group did have fungemia with 2 Candida species. And then, like I said, no statistical difference between ICU or hospital length of stay. Therefore, with our results, we were expecting a different outcome, and I think that this could be due to the time frame that we would typically expect to see PN-ALD, which is typically going to be around our 14-day mark that I noted at the beginning of the presentation. And if we recall, the median duration of PN in our study was about 8 to 9 days. So we recommend that future studies should aim to examine similar outcomes among longer durations of parental nutrition. Beyond this being a retrospective study with a small sample size, we do believe that it's hard to account for a lot of our confounding variables, even with our recording of these. We've already discussed duration of PN, but we also think some medication confounders and critical illness could also contribute to our findings here. I would like to acknowledge my co-investigators and my participation in the ASHP Aspen Nutrition Support Program. And I will end with a self-assessment question. So true or false, in our study, there was no significant difference in the rate of PN-ALD among hospitalized patients receiving either olive oil-based or soybean oil-based lipid emulsions as a component of PN. And that is true. That concludes my presentation. I'll now take any questions that you guys have. Okay, thank you.
Great job, guys. Gonna get the much awaited code for you guys. Here is your CE code for this session. All right, thanks everybody.